Pain is a good thing for a lot of situations. It's designed to make us safe.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
The dread Pirate Roberts tells us in The Princess Bride that life is pain, Highness. Anyone who says differently is selling something. Hello, I'm Bill Monroe, and welcome to episode 181 of the Strokecast. What is chronic pain? And speaking of selling something, this episode is brought to you by the fine folks at Modus Nova. To find out if Modus Nova can help you recover the use of a stroke-affected limb, visit strokecast.com/Modus Nova. If you live with chronic pain, your body doesn't actually get used to it. In fact, it becomes even more sensitive to pain, and that really sucks. In episode 38, I talked with actress Maggie Whittum about her experience living with chronic pain after her stroke. We've heard similar things from other survivors as well. Because of the neurological damage from stroke, survivors can live with real pain in their limbs, face, or elsewhere, even if there is nothing wrong with that body part. But why is that? In this episode, I speak with physiotherapist and pain researcher Brendon Haslam about the nature of post-stroke pain and how to treat it. We also talk about his recent research that shows that stroke survivors with chronic pain often feel that their affected hand is larger or smaller than it used to be, which is really interesting, and we talk about what that means for pain treatment. And as a little bonus, in contrast to the darkness of pain, we get to hear the birds in the background as he talks to us from a rural community in Australia. So now, let's meet Brendon Haslam. So Brendon, thank you so much for joining us on the show this week.
No, my pleasure. Thanks for the invite. Looking forward to it.
You know, your research and expertise is very interesting. So let's start off with probably one of the most basic and probably one of the most complicated questions altogether in this field, and that is, what is pain?
Question is certainly one of the more complicated ones, because I think what we previously used completely wrong. So pain, actually, there aren't any receptors in there. There aren't any pain pathways there. There are lots of receptors that are out there about touch sensation or pressure or position sense or temperature, as well as our body, our brain, whole nervous system sort of basically generates as a means of self-protection, as a means of making us change behavior. So pain as an input, as a sensation is actually not correct anymore, but more pain as an output, like an emotion as well. But the thing with pain is that it has both a physical and an emotional experiential component. So we attribute an experience of pain to a body part that we view is currently under danger. So, but I think importantly, you don't need to be injured for you to have pain in a body part. So pain, fundamentally, the easy answer is it is an output. It's something that our self generates as a means of making us change behavior to more take on a position of safety. So, yeah, the easy answer, the long answer, I'm not quite sure how that sort of goes, but it's very much a change in thinking in the last sort of 20, 25 years. And you'll find a lot of health professionals that were taught in that sort of pre-sort of 2000s will still have been told about pain being an input, or that there are pain receptors. So it's why there's a lot of mixed messages out there in the clinical world, I think.
Well, I think that's really interesting when we talk about it being sort of generated by our nervous system, sort of aligns with one of those things that a lot of stroke survivors have to get used to in thinking about. For example, I live with hemiparesis, but there is nothing wrong with my hand and there is nothing wrong with my leg. The problem is literally all in my head. And it sounds like that's similar to how that experience is, where that is. Pain isn't in the limb. It's created in the head and assigned to the limb in the brain's model.
Yeah, I think that's. I think that's very a very accurate description in. But I think with pain as well as with hemipresis and so motor outputs, sensory inputs, all of these various things, I think after a period of time, it's not just about the brain. There are adaptive changes that occur as a result of maybe an event like stroke in the brain, but over time there are a lot of adaptations that take place, and that's certainly the case in people who experience ongoing pain. I will just sort of grab onto something that you said there, Bill, about this idea of it being all in your head, because in pain that's a real dangerous sort of term, and I'm talking outside of stroke as well here, in that 20-25% of the general population in the world experience ongoing pain due to adaptive processes, but in the nervous system, but they haven't had a stroke, they haven't had an insult to the central nervous system, but their system has had these adaptive changes. And a lot of the language that's used for people with chronic pain is that it's, they may have had great MRIs of showing their spine is absolutely pristine, but they have excruciating back pain, and they're told, oh well, the pain, it's all in your head. There's you're making it up, and I think that's where we need to be really careful with the language, because it can be easily interpreted that it is more of a psychological state. And I'm talking non-stroke states here as well. So this idea of saying that for pain that it's all in your head, I think where we go is that the ultimate decision of whether you experience pain is determined by your brain and everything, but it is as a result of a lot of different information coming in from different systems and how that is processed. So we stay away from that sort of all in your head term, because it often has a bit of a stigma attached to it, because it's implied that for some people their pain isn't real. So it's a funny one. We in pain science we're really pedantic about some of our language that we use, and the implications of how people can receive that is really crucial, because the beliefs that they have about their condition and their understanding actually are a big driving factor in how we go about changing that ultimately.
100%. And I love the pendacity. That is awesome. You mentioned the adaptations as things go on into where we start experiencing pain. And of course, before I go there, I do also want to touch on, I think a lot of us have heard of the idea of things like quote unquote phantom pain that folks who've experienced amputation may experience. That's 100% real pain in a limb that physically isn't there anymore. So you mentioned the adaptations that happen over time. What sort of adaptations are those?
If we sort of look at the adaptations that take place, and these occur in all people who experience ongoing pain, whether they've had a stroke or not. But with stroke, things are a bit more sort of primed to sort of happen, and we see pain in the stroke population. People with stroke, unfortunately, are 2 to 3 times more likely to experience chronic pain than someone without a stroke. And there's a number of reasons for that. But I think if we look at the adaptations that occur in people with ongoing pain, and the term chronic pain basically just means someone who's had pain for more than 3 months, is that in people who experience ongoing pain, is that their nervous system can become more sensitive. It's sort of like it goes out to be on higher alert. So at the point of where some of the sensory information that can come in from the body, from touch, from position sense, etc., where that information comes in to the spinal cord, and those messages are first relayed to the central nervous system, is that the system can actually make adaptations and put down almost like more receiving gates at that point. So information that might come in, for example, about light touch, that stimulates the receptor in the skin. As you know, in a stroke, the peripheral body hasn't had an injury to it. So the nerve that connects that receptor in the skin is intact, carries the message to the spinal cord about, light touch coming into contact with a particular object. But then at the point of the spinal cord, the volume switch of that message, because of these extra receiving gates that are laid down, gets turned up. So the volume switch turns it up. So a stimulus that normally might be quite, innocuous, maybe, just a fine little detail, can suddenly become incredibly loud and hard to ignore and can easily become threatening. So our system can then, in response to this threatening information, is more likely to evoke a state of ongoing pain because something's going on here. I need to protect myself from it. Pain is an ultimate way of protection because it makes me do things differently. It will make me stop interacting with that stimulus. I'll pull away, or I'll move away from something, or I'll go into a place where there isn't as much things going on. So this idea of a state being centrally sensitized. So when information gets into the central nervous system, basically the volume switch gets ramped up. But this state of central sensitization, I think, needs to be thought of beyond pain. And you could, for exactly the same thing, consider someone who is a concert pianist, who has exactly the same nerve endings, muscles, joints as the rest of us. But their system over time becomes so in tune to the fact that this information coming in from the fingers hitting the keys is so important that it also makes adaptations to streamline. So you can become centrally sensitized in a positive way as well, as part of skill acquisition that lets you refine and get the most out of your hardware. And pain is basically a learnt, or the idea of ongoing pain becomes a learnt process and a bit like a skill acquisition. The body becomes, or the self becomes, incredibly skilled at evoking a protective behavior such as pain in order for it to feel safe. Does that sort of make sense?
That does make a lot of sense in a couple of ways. In one level, it's counterintuitive because we have the perception that the more you experience something, the more you become numb to it. But it sounds like that's just the opposite of what's happening here. At the same time, that aligns with what we know about the core principle of neuroplasticity that makes recovery possible. The nerves that fire together wire together. The more time you spend in an activity, the more brain real estate will be devoted to it. And when we talk about the concert pianist, we've talked about the model of the homunculus before as demonstrating the brain neuronal real estate occupied by functions. And so it seems like this aligns with a lot of those ideas.
Absolutely, and I think that's sort of the part two. So of part one, this adaptive process, you've got a sensitization of the system where information is given more value, but then also at the homuncular level, you start to get changes in how the self represents itself. Sorry, that's a bad choice of words, but how the self has this representation. So, and with ongoing protective behavior and potentially lack of use and changes in that, then we see further changes at the homuncular level where the system rearranges to the demand that's coming in. So the concert pianist will have further refinement of the motor and sensory homunculus of their brain representing the hand. That will become more and more refined and more precise at being able to activate particular areas and inhibit other areas. In something like an ongoing pain state, where there's this adaptive processes and potentially a lack of engagement with external stimulus or movement in an effort to try and reduce pain or minimize pain, then that also then drives further homuncular changes that are beyond the initial stroke itself. And we know post-stroke without pain that we continually see changes and we can drive changes to be adaptive or maladaptive. but it's a constant change of flux, and pain should just be, it should be thought of as part of the whole situation rather than something out on its own, because it's quite normal for us to experience pain. Pain is a good thing for a lot of situations. It's designed to make us safe, but ongoing pain where it is occurring in response to, stimulus or environments that actually aren't likely to cause injury, then has a negative effect. We need to be thinking of pain as a normal experience, as part of our day-to-day sort of things, and an important one, in the right context.
I know when I go through a painful procedure, whether that's getting my Botox and Dysport injections or some dental care or whatnot, I try and sit there reminding myself through my head, pain is just data, pain is just data, pain is just data. It's trying to warn me of something, and this situation does not require warning.
I think that's it, and I think what we want to look at in terms of pain is that, you will experience pain if there is more evidence of danger than there is of safety, if there is determined a need to protect. So one of the things that what you're saying with that sort of mantra of pain being data or data for me, is on one hand, I sort of go, that sort of fits with the old pain as a sensation, pain stimulus, pain receptors, pain pathway, which I sort of don't love so much. But the mantra of what you're basically saying is that what I'm experiencing now is, yes, it is a stimulus, yes, there is going on, but there is a greater good for it. So I'm going in a state of control, and that I'm actually quite safe. There's not going to be any damage that occurs as a result of this, and actually the results, the benefits of it outweigh. So you go in a point of control, which is a massive thing, because you have an overall awareness of being safe. If it was a different person that did the injection for you in a different context, and you'd heard different reputations about this person and their skills in putting in Botox and stuff like that, there may be a little bit more threat value than going into the regular clinic that you have with the same old sort of procedure. It's always about building evidence of safety.
So very different than if somebody hits me with a needle in a bar.
Absolutely. And you don't know what's in it, all of that sort of context. It's ultimately the same stimulus that is going in, but the context and the evidence and the control that you have over that stimulus is very different. So in a treatment mode, we're constantly looking to what are the threats, what is the evidence of danger in this particular sort of situation, and how do we build more evidence of safety so that the scales tip more towards safety rather than danger, and then we start influencing pain.
That idea of tipping the scales, that makes a lot of sense. I really like that explanation. What is it about stroke in particular that leads to this chronic pain, that leads to this dialing up of these central nervous system in responding to the stimulus?
Great question, and that's something that we've really sort of tried to really explore. We know 2 to 3 times more likely than general population, but we also know that very few people who experience ongoing pain following their stroke experience pain in the early days, in that acute setting. So it's more experienced over a period of weeks to months that people first start to experience pain. So it is suggestive from that it's actually not a hardwired state. It's not actually the stroke itself that has caused the pain, but maybe the stroke has created an environment that leads to a state where it's perceived to need more protection. And it's considered to be sort of a 3-step sort of process. One, immediately following stroke and in that sort of subacute or sort of in that acute stage, there is evidence that the nervous system has a lack of inhibition. It has a decreased ability to be able to quieten down and sift through information that is coming in for what is relevant and what is not. So a system post-stroke can be overwhelmed because it loses the ability to quieten down information that isn't relevant to the task. So it continually gets bombarded with information that normally, we would select and go, not relevant for that. I'm doing this. I don't need to worry about the noises that are in the background. That's not important to me. But in a state following stroke where there is difficulty with this inhibition, siphoning out, picking out the information that is relevant to the task becomes much harder. So it becomes harder to focus on particular things, harder to shut down other information. So there can lead to a state of overwhelmment. Then we also see through change behavior, we see some of these adaptive processes such as central sensitization, and then the further adaptive of homuncular changes. So where the body representation in the motor sensory cortex starts to change and become less precise. So what you have is this sort of perfect storm. You have a self who has difficulty in siphoning out what is relevant at that point in time and what is not. You have a situation that turns up the volume switch of information coming in, and then because of changes at how the body is represented and a loss of precision in being able to really pick and choose, you have a state that isn't then able to make sense of the incredibly loud, busy information that's coming in. So it's a bit like, in some ways, you've got someone shouting at you in a language that you don't understand. So first of all, they're shouting at you, but there's lots of other stuff going on. The language, the vocal that they're using is incredibly loud. But then at a cortical level, that information that's coming in very loud is also not as easily understood. So if I shout at someone and say, go in and go, "Hi Bill, how are you today? Isn't it a great day? I love the sun is shining, blah blah blah." Your initial response might be like, "Oh, that sort of, hang on, what's going on? Why is he shouting at me?" But then you start to make sense of what I'm saying, and you go, "Oh, okay, all right, this guy's probably harmless. Maybe he's a bit deaf and that's why he's shouting a bit more, but actually he's okay." But if I shout at you in a language that you don't understand, it has a lot more threat value. And it can be like, okay, well, hey, am I safe here? Is this guy about to hit me? Because you don't clearly understand what's going on. So in that state of pain where you have that lack of inhibition, you have adaptive processes of turning the volume switch up, plus then you have changes in how the self is represented, really makes it hard for people to maintain an ongoing state of safety into different environments. They're much more easily threatened and more likely to evoke a state of pain as a protective behavior to try and make themselves feel safe.
I want to talk about body representation in just a moment, but one of the things that jumps out at me about that discussion is the whole concept of inhibition, because this comes up again and again in the stroke world, the ability of the brain to not inhibit things it normally does or it used to do. We just had a recent interview with Dr. Wayne Feng from Duke University about tone and spasticity.
Yep.
Part of the reason we experience tone and spasticity is that a lot of times the brain's default behavior is to inhibit the flexors in our arms that promote fists and arm curling. But after stroke, the brain is often no longer able to inhibit that, so we naturally flex, and that drives tone and spasticity.
Yep.
A lot of survivors I know don't go out without wearing their sunglasses or their headphones because there's so much more environmental noise and visual noise out there. They need to dial it down because the brain can't filter all that out and inhibit its response. And so it can become overwhelming. And now it sounds like the same thing is at play with some of the pain receptors or pain reception.
Or pain production, I think.
Pain production. Absolutely.
So you've got production of pain based on an inability of the system to pick and choose the information that's coming in that is relevant to the task. So yeah, absolutely. I think a key thing is this notion of inhibition as being incredibly important for all aspects. So for movement, it's you need to be able to excite and activate, one muscle group, but you also need to be able to inhibit the opposing one in order for it to happen. So you're in this constant state of flux. And if you completely take out that muscle that is, that you're looking to inhibit, then that's not great functionally wise either, because you need to be able to constantly be altering inhibition and excitation. And, think of that concert pianist, they are constantly on the go, and, each time that they need to produce a different note or hit a different key, they need to quieten down this part and excite this part. So it is this constant dynamic flux. One of the fascinating things that is going on from a pain level and talking about inhibition is that, for some people they experience something like what's called allodynia, where they experience pain to a stimulus that normally wouldn't be perceived as particularly threatening. So for some people, they can't handle being lightly touched. If their hand brushes against fabric, or if someone comes towards them and touches them without knowing, it brings on an incredible amount of pain, because the system is like, what the hell is going on down here? And so there is this hypersensitivity, and that's through central sensitization and the cortical changes that we've already discussed. And the old school thinking about how to treat that was basically this idea of desensitization, just, constantly having the person rub it with a towel and a tea towel and various things, and basically just bombard the system so that it became better at sucking it up. And the interesting thing with the research that's going on is that what that showed, this idea of desensitization, what it showed was that it was effective for getting people to be able to tolerate more. But it wasn't effective at reducing pain. So they were able to suck it up and handle the stimulus more, but their pain levels stayed the same. So that threat was still there, but they just could grit their teeth through it a little bit more. And what we now know is that we actually need to take, rather than the suck it up and do more approach, which was very much the outdated model of pain management clinics, was that we need to actually go, okay, what is the information that's coming in? And clearly that information is threatening. So the system starts trying to switch off to it. And this is that sort of suck it up and do more. What we now do is no, what we need to do is retrain the system so that it can make sense of that information. And it can start to work out, hang on, exactly what is this information? So it's asking questions of it. It's constantly analysing it. So, and by the greater understanding, we're almost sort of like, putting it back into, the native language. By increasing the understanding of that information, that evokes more of a state of safety. So from a sensory perspective, if we go into retraining sensation so that that person is better able to make sense of the information that's coming in, then we're more likely to see a reduction in pain. Not only are they able to do more, but they are able to do more with comfort. And this approach is now coming through very strongly in the pain literature in the non-stroke world. And what we are sort of doing is taking that and running with it. The lab that I'm involved with is very big on somatosensation and sensory retraining and assessment. And we're now sort of going into sensory retraining as a means of reducing pain and increasing function as well.
Now, it's really interesting when we talk about that, too, because it calls back, I can take 2 cans of soda out of the refrigerator, hold one in my unaffected side and one in my affected side, and the affected side will start burning with the cold pain in short order when the other hand doesn't, even though they're identical. And so it's very interesting to see the brain trying to adapt to those perceptions.
Yeah, absolutely. And it's that constant state of flux. So we almost need to bring in the more affected side into the game and really give it sensory experience, but demand that it processes. So not just expose it, but actually demand skill refinement in how it interprets information, so that we're almost getting it matching to the less affected side, I think. And but interesting, we do see changes in sensory wise on both sides following a stroke. For a lot of people, obviously more marked on the classically more affected side, but it's not unusual to see some sensory changes on the less affected side as well. But yeah, this constant state of flux, and we want to bring everything into the game, so that each person is able to process and pick and choose the information that is relevant to what they are doing, in order to be able to do it better, and not only do it better, but we would argue, with comfort and potentially the ability to enjoy doing it as well. And that's a whole another story when we start getting into enjoyment and fulfillment.
One of the things that really drew attention and why I wanted to talk with you to begin with was you had a recent study showing how experiencing chronic pain as a stroke survivor actually influences their perception of the physical side of their limb. Can you tell us a little bit about that research?
It was a fascinating thing. We did a study looking at, it was over 500 people with stroke, with and without chronic pain. And we just asked some really simple questions, but one of the things that we were really interested in, body schema, body image, body perception, and looking at this body perception. How do people with stroke perceive the size or the shape of their body parts? And we were particularly interested in the upper limb. And given that the hand is so crucial as an exploratory tool to interact with the environment and a lot of functional tasks, we just asked, since your stroke, does your affected hand now feel like it's a different size? Just a very simple yes or no. And what we found was, for people who didn't experience chronic pain, is that around about 10% were saying, yes, actually, since my stroke, my hand now feels a different size. But then when we asked the same question of those that experienced ongoing pain, we actually saw that they were, 2 to 3 times more likely to say, actually, my hand now does feel like it's a different size. Some would say bigger, some would say smaller. And interestingly, that was whether they had pain in their hand or not, or pain attributed to their hand. So some people with back pain, without any pain attributed to their hand, would still report that their hand now felt a different size. But then if it was people with pain that was experienced attributed to their hand, they were more likely again to say that their hand now felt a different size. And this is sort of also known. There's other states that do have altered body image, where the shape of their body feels like has a different outline. People with long-standing back pain who haven't had a stroke often report missing areas where their back just feels like it's not there, or it's a different size, or various things. So it's actually remarkably common, but I think it's the first time it's been really explored in people with stroke, that, and a lot of people in stroke sort of report to a state of neglect. This wasn't about neglect. This was about, my hand actually feels like it is bigger or it is smaller, even though I look at it and I can see that it's not. It feels to me that it is bigger, or it feels like it is different to how it used to be. And having pain, the ratios just jumped enormously. Those that had chronic pain, much more likely to report that their hand now felt a different size. And that gives us a really good insight into, okay, well, what's going on to cause that? And potentially, what are potential treatment targets? Can we actually target this representation, this idea of body image? And could that be a way of influencing and actually changing pain states as well? So, yes, there's this relationship, but can it work both ways? Can the ongoing experience of pain drive this altered body perception? or body image, but also can altered body images drive states of ongoing pain? So can we influence one to the other and how we go about it? So it puts a lot more in the game for us, and I think it adds more repertoire for how we can go in to influence different things for different people. So it's a really exciting paper from a very, very straightforward question, but the amount of interest that we've had from the research community and from the stroke community sort of worldwide has been quite remarkable. The more exposure that we get out there about the problem of chronic pain for people with stroke, and getting people thinking about, okay, well, maybe maybe that doesn't have to be a sentence. It doesn't have to be, oh, well, you've had a stroke and you've got pain, unfortunately, bad luck. It might be like, okay, if we get people aware of that situation, but also aware that it's a state of flux and that we should be able to change it, the more public awareness of that, that's going to drive more research and more clinical change about saying, actually, we need to get on board with this. We need to look into this more, get what are the things that can change it, right? How are we going about that? And getting that out more into the more sort of public clinical knowledge, so that therapists and medicos can be, going, right, okay, now I heard about that. What were they, what were the things? That's something that we can change, rather than just going, okay, well, here's some extra medication, hopefully that does the job for you. The more public awareness that we've got, and this idea of altered body perception, I think is a really exciting way of opening the door for stuff. And it's something that we're really chasing up in a lot of detail in our current research, but also in future stuff that we've got planned.
Well, it's fascinating stuff, because I think it also touches on something sort of fundamental cultural fears. We have very complex relationships with our hands, and horror stories abound of, is my hand not my hand? Do I have control over it? Is it being taken over? So I think there's something, for lack of a better term, in my complete lack of understanding of psychology, there's something very Jungian about the perception of our hand.
Absolutely. I think, the hand is such the exploratory tool to the rest of the environment. And, if you think what we classically see is some people with altered sensation, is that they have the motor control to be able to grab something and hold it. But as soon as they're distracted and doing something else, they drop it, because they have to give this visual attention to their hand in order for it continues to do the task, rather than this being this constant exploratory tool that is constantly weighing up information about the environment. And the idea that if the hand is altered in shape in some size, adds to potential vulnerability of it not being right, and you may be less likely to engage in some of those natural stimulus. But also, the hand is how we measure a lot of things. So if we have a distorted representation of the size of our hand, then it also is going to distort the perceived size and measurements and qualities of any object that it interacts with. So some objects will be measured up as being bigger or smaller, or some edges may be seen to be, like more prominent than others, and potentially more threatening, because the hand as a reference point has now a disturbed baseline setting. So therefore, everything that is measured in relation to the hand is also going to be skewed. So the hand is really crucial to how we perceive our environment. Second probably only to vision, is how we measure up and process the world. And if you take that out or distort that, then you're really selling people short about what they can get in and out of doing. And people become very much more visual dominant about that.
And when people then start having to compare maybe something they can explore with their less affected side as compared to their affected side, now you've got some cognitive dissonance about trying to align these two different perceptions based on this misperception of your hand now.
Absolutely. And then, that can lead to then, actually, this is just too hard. I'm just going to do it all with my with my less affected hand that has a better representation. So we then evoke more of a state of lack of misuse, which then drives further maladaptive changes as well. So, we want that hand in the game. But we need to create an environment where it is where it's relearning. So that it's not just sucking up and doing more or being completely shut out of the picture. It's actually engaged in those things, and we're demanding information that it is able to offer through exploration of into different objects, different surfaces, evoking of different pressure from muscular control, all of those different things. It is more about embracing it. If we're going to try and change a state, we need to demand more positive learning. Rather than, lack of or, going into a misuse or maladaptive learning as well. We want to drive it towards positive.
Absolutely. Absolutely. So we've got this association between chronic pain and change in perception of hand size now, which then, of course, influences all of these other challenges, leading to potentially more learned non-use and not trusting it and the cognitive dissonance and all these other things that come into play. So stepping back then to that chronic pain, with your background specifically as a physiotherapist, so what can a physical therapist or a physiotherapist do to help patients address their chronic pain?
First of all, we need to provide education. We need to provide education about actually what is going on for this particular person, because the very much public perception in a non-stroke world with chronic pain is that there is an ongoing injury, and that the injury hasn't healed itself. So if someone has that persisting belief, it's very hard for anything that a physical therapist, physiotherapist, depending on where you live, is able to do, because, if the injury has already healed but the state is in an ongoing state of protection, trying to provide more treatment to that body part on a flawed model of the idea of an ongoing injury is never going to work. Lots of great work about educating people with chronic pain about, what's going on. Why does someone continue to experience pain in an ongoing thing after a tissue injury? And about central sensitization and all that changes. And that approach has been shown to be very effective in general chronic pain populations. What we did, because we wanted to find out, was that what do people with stroke actually believe about their pain? Because in order for us to be able to change it, we need to find out what they believe, so that we can then provide education about that and start to set up a learning environment. And if you can do all the best treatments in the world, but if it doesn't fit with what that person believes is actually going on, they will not work. Overwhelmingly, what we actually found was that people with stroke, was that fundamentally, when we asked clinicians about why do people with stroke have ongoing pain, a lot of the clinicians were going with that ongoing injury model and the classic shoulder subluxation and hemiplegic shoulders, and that was the cause. There were these musculoskeletal, it's because of tissue damage or underload, which has been shown to be a flawed model as well. So the clinicians were thinking more that there were still ongoing tissue injuries of the body. And there may be for some people. The people with stroke that we interviewed actually firmly believed the other way, is that they attributed their pain directly to the stroke itself. And then as a secondary, they indicated that there were also adaptive changes to their nervous system that had happened as a result. But primarily, the stroke itself is causing it. So as an educational target, we need to look at that as well, because if that is the thinking, then no matter what anyone can do, we can't undo a stroke. So therefore, how are we going to change someone's pain? Looking at that and looking then with the knowledge that people post-stroke often develop pain in the weeks to months following the stroke, gives us good ammunition that actually, it's not the stroke that is directly causing the pain. It is actually more these changes to the nervous system that have happened following the stroke and maybe as a result of the stroke or in response to the stroke, so that we set up a state of dynamic change. And can we then, okay, well, your system has driven towards this adaptive state of protection. Let's build up more and more evidence that the body and the self is actually safe. So how can we do that? But first of all, we need to provide this education so that we get people on board with what we're actually trying to do. And then it's like, okay, so now what we can do is how can we build up that body of evidence? What are the particular threats that are going on? Is it to some particular movement patterns? Is it to some sensory stimulus? Is it to some other environmental context? What's the role of stress playing into it? Is there a fatigue factor? All of these different things then create a bit of a hit list for us where we can go in and go, okay, how do we rebuild and refine this person that I'm working with so that their system is more efficient, is able to process information about themselves and the environment that they're in a way where there is lack of or a reduction in threat and an increase in safety. So it makes sense for me as a physical-based therapist, which I think is now we're broadening that because we're having much more of a psychological approach as well, and educational. But it's like, how can we refine? How can we rebuild? How can we retrain that homuncular, that sensory motor homunculus, so that it is better at processing and making decisions about that? How can we influence states of central sensitization so that how can we train the system to be able to inhibit better, and bring in things like that, and then, as that final piece, how do we retrain the body to have better awareness? So what are the things that contribute to that person's perception of themselves? So we can look at sensory retraining. We can look at things like the use of imagery and visual illusion and virtual reality contexts as well. So we can, use the visual system to reinforce the integrity and the safety of the body itself. So you're looking to rebuild this body image through visual, through educational, through sensory, through motor representations, changes in the task. So we're really trying to retrain that or refine that homunculus, but also then looking at what are the other factors that are going on for this person that are using up energy. So is there an ongoing state of stress or fatigue from that, which makes it harder for someone to be able to process properly, and then they're more likely to become overwhelmed because the battery pack is just not as full. So my job as that sort of therapist is to look at identifying all of those contributions and then go, right, where do we start? But I guess traditionally we would say in this sort of physical-based, it is about building a better body representation through sensory, motor, visual, all that.
And one of the tools that is not mentioned in that discussion really is the use of pain medication. So, I mean, what role, if any, does medication have in working with chronic pain after stroke?
Absolutely, and I think it's a really important question. It's a really important issue because medication can play a really positive role. But it's important to know what the medication is trying to do. And classic pain analgesic medications, such as the use of opioids, are very helpful in an acute pain situation. Where there has been acute trauma or surgery or very much like that acute injury-based model, that classic pain analgesic is absolutely appropriate. But in an ongoing pain state, those classic pain analgesics are very, have very little effect in ongoing pain states. And actually, there's now some evidence that they can actually, in ongoing use, can actually drive a state of sensitization even further. So there's a big shift away from that as an ongoing medication. the frontline medications that are being used more in ongoing pain states, and particularly with people that may have a neuropathic type component where this sensitization occurs, where the volume switch is dialed up, are medications that are classically considered to be more anticonvulsants. So some of the epilepsy medications. So this is some of the things like pregabalin and gabapentin, and some of the antidepressants, in particular the tricyclic antidepressants. Those medications actually work at the level of the ion channel of where the information is passed on from one to the other. So if we consider information coming in from the peripheral nervous system into the spinal cord, where it's first transmitted, and in a state of central sensitization, lots more gates at that level, so the volume switch gets ramped up. Medications like some of the anticonvulsants or some of the antidepressants, particular types, target particular ion channels or particular gates and block them. So those medications are basically trying to turn the volume switch down to a more manageable level where that person isn't going to be overwhelmed by. So it basically stops the system shouting. So it has that sort of suppressing effect, and that makes sense from an epilepsy medication. It's trying to tone down that overriding state of excitement. So it's trying to do that from a pain perspective as well, in ramping down that high level of noise.
And especially since the earlier discussion we were having about questions of inhibition, and if the brain is having trouble inhibiting things, it sounds like these medications help the brain with that, drive that inhibition.
Absolutely. So they selectively target different ones, and different medications target different ion channels. But one of the things that we need to consider is that the use of a medication such as those are non-selective. So it can dampen down the whole system. So some people may not tolerate some of those medications very well, and may find that they contribute to a state of fatigue or memory issues, short-term memory problems or things, because the system is calmed down too much. So it goes into a sleepy fatigue state. So some people don't tolerate those medications. Sure. So it is about getting the right fit for the right person. It's important to understand the role of what the medications are trying to do. And unfortunately, sometimes the education when those medications are prescribed isn't so great. And if you think of a situation of, I go in to see my general practitioner, my local doctor, and I'm complaining of pain, and they prescribe me an antidepressant. And they say, here, I want you to take this. And I go home and Google what that medication is. And it's an antidepressant. My initial response and a lot of people will sort of go, okay, well, that was a waste of time, because that doctor doesn't believe that my pain is real. They just think that I'm depressed. Whereas if you introduce the medication with, this is what it's trying to do, it's more likely to be received well and for people to be compliant with it, because they are understanding more what it's trying to do, rather than if you take a medication blindly and then some days you have less pain, but then other days when you take it, you still have more pain, and you don't understand what it's trying to do. You might sort of say, well, that's useless. That doesn't work because it didn't reduce the pain, rather than looking at what's the overall scale, of evidence of safety, evidence of danger. Did I have a crap night's sleep last night? Did I have a curry that my stomach is a bit upset, that my system is under more load? I'm more likely to have ongoing pain because my system is less likely to be able to pick and choose the information that's relevant. So medications can have a great role done well. But
that setting that expectation is key for the patient, between the doctor and the patient. Absolutely.
And it's a big thing that we've done, a lot of work on, and some of my colleagues in non-stroke pain states, is about education towards effective pain medications. Yeah.
So one of the other things that we're seeing, at least in the U.S. here, and I understand we're seeing a little bit more around the world now, as opiates are becoming harder to get legally, we're seeing more and more people explore medical or recreational marijuana for self-medication purposes, because a lot of doctors, even where it's kind of legal at the local level, but not at the federal level, are reluctant to go ahead and recommend. What are your current thoughts and the science about the role of marijuana or cannabinoids in addressing pain from either an official or self-medication perspective?
Yeah, look, I think it's a really great topic, and it's fascinating, and I think, there's lots of different schools of thought, and I know here in Australia there is this view that the use of medical marijuana, recreational marijuana, CBD oil, various sorts of things, there's this public perception that the medical profession are against it in the use of ongoing pain. And I don't think that's an accurate reflection. There's no doubt that it can be an effective therapy intervention strategy for some people, and there are some people that have fantastic effect from it. There are also some people, of course, don't tolerate it, and the side effects are overwhelm, and the out of body experience and the apathy, and they decrease participation. But I think if we consider those people that can use it and use it in a positive sort of way, there's no doubt that there is a clinical effect. But what we see is in a numbers needed to treat. So in terms of medications for pain, classically we describe medication's effectiveness in a numbers needed to treat. So how many people need to take one particular type of medication in order for one person to get a 50% reduction in pain or a 30% reduction in pain at a clinical significance level? What we see is that the number needed to treat for something like marijuana, CBD oil, those various sorts of things, is much, much higher than the number needed to treat for those frontline medications, such as the anticonvulsants, in particular, like your tricyclic antidepressants. So it's more about thinking of it as a horse race. And if you're able to put one bet on, if you only have a chance to put one bet on, your best chance, what you're going to do is you're going to back the favorite. You're going to back the one that has the biggest chance of winning. And that may or may not work for that particular person. So the medical profession are more likely to prescribe, more likely to recommend particular medications before the use of some of the cannabinoids and stuff, simply because they expect a more positive hit rate, a more positive effect rate. So you'll go with the favorites first, but then if you don't get the effect from that, because it might be a particular ion channel that is as part of the sensitization sort of thing, you'll try the next. And so the use of marijuana, cannabinoids, sort of CBD, various bits, is certainly part of the toolbox, part of the armory. But it may not necessarily be the one that is most likely to get the biggest benefit for the mass population. But for some people, it is exactly the one that fits the right box, and it can be used incredibly effectively. It is very much a matter of looking at the individual and what are the things that are contributing towards that person.
Well, I think it's great that we're seeing a more nuanced conversation around it, which is something that historically we haven't necessarily seen, from advocates arguing it's a cure-all for everything and opponents arguing that it's the devil incarnate. So we're starting to see a little bit more.
In order to get a media story out there, it's got to be polarizing in one way or the other, because it's got to spark attention. So the middle ground doesn't make news. Because it's got to be a headline, and it was one of the things with this paper that we had about the altered hand size, was that it had a novelty to it in its topic. It had a little bit of an interest factor compared to some of the other stuff that may be just as relevant, but it doesn't grab the headlines. It doesn't capture public attention. So sometimes you've got to put the polarizing out there in order to drive the middle ground. But I think from a research community, the research community in the pain world is very much aware of the role that it has, and there's some really fascinating studies and large scale studies that are looking to show effectiveness of the various approaches, and particularly what we're trying to do, and in non-medication based, but in some of the medication studies that other groups are doing, is trying to get a profiling situation where we can create a profile for this person that we're working with and go, okay, based on this person, they are more likely to respond to this particular type of medication or this particular intervention based on the symptoms that they are experiencing and what's going on. So it is about getting into big data sets and being able to look at symptomatic profiling and responsiveness rather than just thinking of one medication for all people with post-stroke pain or one intervention. Actually looking at, okay, how effective is this intervention or this medication for people who experience pain that has this symptomatic nature, and maybe that will be more responsive to this than some others. So we're getting there, and we're getting more streamlined. And I think the use of classically alternative medications or alternative treatment options are now being able to come into that foray a little bit more as we understand more and more.
And I think it sounds like there is a much bigger conversation that could be had about the role of ethical marketing in headlines on research reports.
Absolutely.
and general science communication.
You've got to play the game. Not, a lot of research is out there, but it only gets to the research community. It doesn't even get to the clinical community. Like, we're having clinicians that aren't aware of the current research that is going on. We've got people that are saying, okay, well, you've got ongoing pain, there's nothing you can do about it. Here, get some extra medication and, good luck. We need to be driving things at all things about engaging with the clinical community, but also with the client patient population. And we've engaged really closely with the Stroke Foundation here in Australia. And they've been partners on some of our research projects, so that we really get this engagement, and they are sitting in our planning meetings and involved in the actual design of research. And that's where it needs to go. We need to be all embracing, because the questions that we have aren't necessarily the questions that a lot of other people have, and things that we think might be important may not be so important. So and therefore they're not going to be received publicly. So it is constantly a game of there, and we, it's why for me, your invitation, for this is something that I feel really passionate about, because the more that we can get information out there to people, the better we can be in our effectiveness in driving change and improving quality of life for people.
Absolutely. So what drove you to get into this game anyway, to pursue this route of physiotherapy and pain research?
Look, I went into physiotherapy, physical therapy, the classic sort of, and I started studying it in the late 80s, when it was sort of seen as a bit of a sexy profession in the sporting community. Professional sports were there, and there'd be an injury, and out would run the physio onto the thing, and it was like, oh, how fantastic is this? That's, I'm interested in sport. This is exactly what I do. I don't want to do medicine, but this seems to fits all my interests, and that's what got me in there. And then, but as I started working clinically, I was lucky enough to work at a major hospital as one of the new graduates, and did a lot of rotations, and I actually found that sports injury model actually quite frustrating and boring, which a lot of my friends went, what do you mean? But I found I got thrown into a stroke unit on my very first clinic, and it was incredibly progressive, and it was just fascinating. And it was like, this is where I want to be. This is where I feel I can make meaningful change and get satisfaction and have ongoing interest. And it's such a fascinating area based on learning. The science behind it is so fascinating. So I worked in neurological rehabilitation here in Australia and throughout various places in the United Kingdom as well. And then when I settled back in Australia, I took on a senior position in a rehabilitation unit that also had a significant pain clinic associated with it. And it just became obvious the overlap that was going on. All these people with ongoing pain that hadn't had neurological conditions, but some of the stuff that was there, and there was a real boom in the pain science there, and it was like, hang on, and we need to get these people with ongoing pain moving better, using some of the neurological approaches. But then what's going on in the pain world, and why isn't this being used in a neurological population? Why was this ongoing thing of, oh, well, you've got pain, that sort of comes with the territory, bad luck. So it became increasingly frustrating for me as a clinician to see this big gap between two worlds. The pain world weren't taking in all the learnings from the neurological world. The neurological world were stuck in an outdated model of pain. So I was lucky enough to be, to know a couple of sort of key pain researchers and that are based here in Australia, and they're friends of mine. And it was like, what, they get, and it's so frustrating. And they're going, well, what are you going to do about it? So it's like, if you're not going to do it, then who is? So that became, for me, at this age of, in my 40s, I start taking on a PhD part-time while still working full-time to expand the knowledge of chronic pain and stroke, and look towards sort of Parkinson's disease, spinal cord injuries as well, because there was such this unmet need that was always just put in the too hard basket. So it was like, it just became too hard to sit back and not do something about it. So for me, it was about putting it out there, getting it as a platform, getting it onto the topic of conversation, and then maybe something can be done about it, and driving change from that perspective. So it's sort of become a bit of a personal mission. But it's from the science and the learning approach that has fascinated me, that has gone in there. And we're getting momentum, which is exciting.
Right. And it's certainly an incredibly fascinating space that touches on so many different aspects of neurology and biology and just living life as out there.
Yeah, absolutely.
And that brings us to our hack of the week. But first, let's talk about sponsor Modus Nova. If you want to recover the use of a stroke-affected hand or foot, Modus Nova may be able to help. The Modus Hand and Modus Foot are AI-controlled, air-powered exoskeletons that you wear on your limb while you play video games on the included touchscreen monitor. They help you get in the thousands of reps that you need to recover the use of a stroke-affected limb. And the record keeping means that not only can you see your progress, you can also hold yourself accountable for actually doing the work. To find out if Modus Nova can help you recover the use of a stroke-affected limb, visit strokecast.com/Modus Nova. Use promo code STROKECAST to save 10% off your first month. And now back to our hack of the week.
One of the big things is about getting people to regularly engage in meaningful activities that have purpose or joy. So, because what happens if you're doing something that may be physically stimulating, intellectually stimulating, emotionally stimulating, that has a real meaning to it, is that you can consider that there's like a drug cabinet in your brain. And if there is something that has a real purpose, this drug cabinet opens in order to let you be able to do that better. So a meaningful activity that has a real purpose or joy opens this drug cabinet, and you get, adrenaline, noradrenaline, endorphin rush that, creates a state of excitement of information that is relevant to that task. But in opening that, in getting that meaning, it also stimulates dopamine production, which is so crucial for learning. If there isn't enough dopamine in the system, then we don't learn in a rewards-based way. So in order to drive learning, you need to unlock this drug cabinet. You need to be doing meaningful things that gets dopamine going. But also the extra piece de resistance of that is that dopamine is a big factor in driving the release and the production of GABA, so GABA, which is the thing that trickles down the spinal cord and effectively turns down the volume switch of information that's not relevant. So it turns down the sensitization. So if we can create states of meaning, engaging, fulfillment, not only are they good to do at the time, but they also drive learning opportunities. But they also drive a system's skill to be able to start to selectively quieten down information that is not relevant. And then we can actually start to change the pain game. And so not only do you see learning quality of life from a functional perspective, but we start to then be in a situation of modulation and pain reduction as well. So for me, the big thing, what are the things of meaning today? Where am I? What things have meaning for me? What is the purpose? What are things that can give me joy that I can lose myself in? And how do I regularly access that drug cabinet in the brain so that it becomes a bit like a medication? It's like, okay, where are my opportunities for that? Where am I gonna, unleash the drug cabinet? And make sure that each day has 1 or 2 or 3 of those opportunities.
That's great. And that aligns with so much of the other stuff that we've been talking about, not only here, but in other conversations as well. This has been a great discussion, Brendon. If folks want to know more about you and what you're up to, where should they go?
I guess, Dr. Google is a wonderful thing. So of my name there, because of the nature, I have a number of different positions, but my university sort of profile of Brendon Haslam at La Trobe University will go to an updated profile of publications. We can access something like ResearchGate, which has a profile again, and any publications, literature that we've been involved with, other studies. But I'm happy to be contacted directly. One of our big things is about getting the message out. So I'm very happy. People can go through Dr. Google and find out all sorts of things. Hopefully, most of it's good about me. And you'll see I have a few different roles in educating other health professionals and things as well. But it gives you a bit of an idea there.
Great. Thank you so much. This has been a fascinating discussion today. This has been really great. Love learning more about this stuff and sharing it.
No, my pleasure. And sorry, I'm very happy and thank you for the opportunity and the time. I appreciate it.
We talked about the homunculus quite a bit in this week, and it's not the first time it's come up. Basically, the homunculus represents how much space a part of the body occupies in the brain, or how much neuronal real estate. The more we do something or use a body part, naturally the more space it'll occupy in our heads. For example, there are more brain resources dedicated to the thumb than to the elbow because the thumb's structure and daily use is so much more complex than that of the elbow. Not that the elbow is simple. I mean, it's a fascinating topic, and I have another blog post that goes into greater detail about it and includes some images and representations at strokecast.com/homunculus, HOMUNCULUS. You'll also, of course, find that link over at strokecast.com/pain. The other fascinating thing that comes up from today's discussion is the question of inhibition. You see, Brendon describes the increase in chronic pain as coming in part because the sensory gateways that help control the flow of information to the brain actually turn up the volume after stroke and in the context of chronic pain, rather than actively inhibiting that sensation or turning it down. A few episodes back, Dr. Wayne Feng talked about tone and spasticity resulting from the inability of the brain to inhibit a number of those signals that the spinal cord sends out. Peter Levine had talked about how the spinal cord sends those signals to the muscles to contract as well when the brain fails to inhibit them. Multiple survivors that have been on the show, including, but of course not limited to, local Seattle artist Seth Ian Shear and neuronerd Joe Borges, talked about going out with sunglasses and headphones because their brains no longer inhibit all of the sensory data processing that comes into the brain. And having to deal with all of that data coming in and not being able to filter it out is exhausting. We don't often talk about the brain in its role of ignoring and stopping things. The nervous system produces so much more data than the brain can reasonably handle, and the brain spends much of its energy ignoring, filtering, and inhibiting things, and that's just normal pre-stroke life. After stroke, that can become a lot harder for the brain to manage. More sensory data comes through, and we get fatigued just trying to manage it. Or we get overwhelmed and have to extract ourselves from a situation. Fewer pain signals also get suppressed, so we can feel more pain. Fewer signals from the spine get inhibited, and we experience tone and spasticity. The exact mechanisms differ, of course, but it points to another way of thinking about stroke and brain injury in general. It's not just that the brain stops doing active stuff like moving an arm or forming sentences. The brain also no longer stops other things from happening. We tend to think about the former in a systematic way, but not the latter. And perhaps that's where we should start looking at changing things. On another note, I do want to thank everyone who completed the Strokecast listener survey last quarter. And while the prize drawing is over, I will leave the survey live if anyone would still like to share their opinions over at strokecast.com/survey. I'll also, of course, be incorporating those results of the survey into future episode planning. This has been super helpful, and thanks again for your time for everybody who went ahead and completed that at strokecast.com/survey. As I release this episode, it is mid-April. Next month is National Stroke Awareness Month in the US and elsewhere. And if you are so inclined, it's a great time to share your story with others in your community or maybe just even in your household or workplace if they don't already know your story. Share the signs of stroke, the BFAST signs of look for changes in balance, eyesight, facial symmetry, ability to hold both arms up, speech and communications, and remind people that if they observe those, it is time to call an ambulance. So share those signs of stroke, or perhaps tips on preventing stroke, like monitoring your blood pressure. And of course, sometimes just being a part of other people's lives, other people who know you've been through this experience, even if they don't know all the details, and even if you don't go ahead and actively talk about these things, just being a part of people's lives may be all it takes to raise some awareness. And if you're not comfortable talking about your story with others, that's perfectly fine too. To read the study about hand size or learn more about Brendon Haslam, be sure to check out the show notes at strokecast.com/pain. Share this episode with someone you know by giving them the link strokecast.com/pain. If you haven't already done so, go ahead and subscribe to the Strokecast newsletter at strokecast.com/news for periodic updates and thoughts from me about stroke and recovery. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.